your weekly EMS news commentary, and part one of our series on the physiology of pain, coming up this week on the MedicCast.
Transmitters? We don't need no stinking transmitters.
This is the MedicCast, a podcast for EMS providers by EMS providers, featuring EMS news, products, tips, tricks, and commentary. So grab your gear and glove up. Here's today's show with the pod medic, Jamie Davis.
Well, good day and welcome to this week's episode of the MedicCast. I'm your host, Jamie Davis, the Pod Medic, and we're back in the saddle here with some new episodes. You may have noticed that we've been running some reruns and picking up with the final pieces of our recordings from EMS World Expo in Vegas, and then I just had a lot of things going on. So we took a bit of a hiatus for a few weeks, back ready to go with some great episodes to round out 2011 and kick off the beginning of 2012. Just a lot of things I already have in the hopper for the rest of this year, so looking forward to that. In the meantime, I do want to remind you to check out all of the links to everything discussed on this and every other episode, as well as links to all the previous episodes going back to episode 1 6 years ago. You can find all of that over at mediccast.com/blog. You'll find links for show notes right at the top of the page, and you can click back in time and find everything you need there. You'll find links to news articles discussed here, things mentioned in listener email items, and all other segments that we have on the show. So make sure you follow up, as well as check out our links to our Facebook page and sign up for our MedicCast newsletter. I also want to remind you, you can get back in touch with me at podmedic@mac.com. So get in touch with me. I get a lot of emails from you, and I might even share your email here on the show, but I do respond to every email I get. So keep those emails coming in. It's great to get the support from the listeners and viewers here of the MedicCast. So without further ado, we're going to jump right on into our listener mail segment and check into what some of you have been saying, both here on the email and a voicemail message this week on the MedicCast. So we'll go ahead and kick off our listener mail segment here with an email from a good friend and a longtime supporter of the show, Greg Adams, down in New South Wales, Australia. Greg sends me emails periodically with some links to things going on in his area with the paramedic program, both in education and in the actual system on the street. And Greg sent me a link this week to some things that the paramedics or students are doing down there, learning about emergency care and work. It's a great model down in Australia. I hope that we will continue to move in that direction here in the United States, where they have basically a 4-year training program, a bachelor's degree trained paramedic program in New South Wales, and it's exciting to see the things that those paramedics are doing in that system. And I'll have a link in the show notes to Greg's video link that he sent from their system down there, just to check out some of the things they're doing. It's important for us to move from the idea of let's train a paramedic to let's educate a paramedic. I think you become much better as a healthcare professional when you can think critically and be educated about what's going on with that patient, and then make your decisions about the types of treatments you're going to provide, rather than having that more traditional recipe cookbook approach to EMS care, where see this symptom, provide this treatment. I think it's more important that you understand what's going on. And it's one of the reasons we're going to be talking about the physiology of pain later on in this episode, to kind of give you an idea of what's going on in the background when you're thinking about helping a patient deal with pain, when you are assessing a patient's pain. And we'll talk about about that later on in this episode. Greg, thanks for your email. And again, I look forward to getting a bunch of other emails from the rest of you as well. I also heard from a listener, Mike P. from Maine, checking in. He had listened to the recent episode series I did, I think over the summer, where I had, I think it was, was it Scott Keir or no, Chris Kaiser on to talk about narrative writing. And that was right back at the beginning of the summer. Mike was catching up on some back episodes and listened to that and thought he'd share some of his ideas on how to approach narrative writing to write a better narrative and protect yourself both legally and professionally by writing a high quality narrative. It's a little hard to understand in the very beginning here, but he's talking about narrative writing, and the signal clears up a little later on in the call. But let's go ahead and listen to what Mike has to say.
Hi, Jamie. This is Mikey P. from Maine, and I'm paramedic and I'm just catching up on some old podcasts of yours, and I just listened to your podcast that you did on narrative tips back in June. I know it's a little late, but like I said, I'm just catching up, and I'm driving down the highway right now. And I wanted to include something that I've done with narratives. Now, most of our narratives back in Maine are now done online. Most services have access to laptops or desktops at the hospitals, and I find that when I do my narrative, I can write a very good narrative if, instead of doing it directly to the website or to the file program and do my narrative there, I first create my narrative in Microsoft Word. I use one of the word processing programs first. I find that the dictionary, the spell correct, the grammar correct, is much better than a lot of the programs that have their own. Plus, I find that I don't need to create so many questionable abbreviations. I know there was something you guys, you talked about the LOL and those other texting abbreviations. Well, using abbreviations is very tricky, especially there's no standard set of abbreviation for medical terms. Some books, some medical dictionaries have their own versions, but they all vary slightly. And you don't, like you said, don't want to give any lawyers ammunition. So my tip is using one of the word processing programs and then cut and paste or copy and paste to your computer-based running report program, patient care report program, and like you said, I'll read mine 2-3 times, or maybe have my partners read it. Make sure it makes sense. And I think those are good ideas, and I thought it was a very good podcast to get back in June. So, Jamie, keep up the good work. Look forward to hearing more. Take care.
Hey, Mike, thanks a lot. I really appreciate you taking the time to call in on the voicemail line, and I hope the rest of you were able to get that. That idea of doing your report in a word processing program, which is really dedicated to writing. You get the spell check, you get the grammar check, and you end up looking a lot better on paper or on the computer screen than you might feel in person, and that's a good thing. So it's a great suggestion, and I would urge you all to really take that suggestion to heart. There's no reason you have to write your narrative right there in the Run Report software. You can write it anywhere and cut and paste it in, and I think that's a great piece of advice. Mike, thanks for taking the time to call in. Don't forget, all of you can call in as well. The voicemail line is 941-306-3342, 941-30-MEDIC. And Mike was calling in on the road. Sounds like he was using hands-free, the responsible thing to do. So you can put this in your phone and 941-30-MEDIC, and then call in on the voicemail line. And when you're listening to an episode, driving along, and you're screaming at me saying, Jamie, you're an idiot, share that thought with the rest of us. I don't mind. I'm big enough to take it. And let's go ahead and get the information out there. Mike, thanks a lot. And I urge you to email me or call in and share your thoughts as we move into the next 2012 year here at the MedicCast. This is a community effort, and I really rely heavily on input from each and every one of you to help make the show as good as it can be. Let's jump into this week's EMS news and cover some stories from affecting EMS this week. I don't want to say they're all from EMS, but some things that I picked up recently that I thought we should discuss. The healthcare debate is still going on here in the United States, and part of it is around the cost of treating patients and prospective cuts to Medicaid and Medicare. Why does that affect EMS, you might ask? One of the reasons is that a lot of our patients, we see those patients, I won't say a lot, but we see those patients periodically that are using EMS and the emergency departments as primary care resources because they are uninsured or have low insurance levels. Medicaid and Medicare, somewhat of a safety net for that. If there's a cutback in Medicare, for instance, Medicare handling our elderly patients, there's an effect that could happen there where patients who have cutbacks in their care and coverage are going to maybe not call us when they should call us. These are the patients actually that are sick a lot of the times, right? They may stop using certain medications, and so their conditions become more severe because of cutbacks in what they're able to afford in the way of either medications or other types of care. So there's a lot of effects from that. The other side of it is the Medicaid part of the package. These are for individuals that are disabled, not necessarily elderly. They haven't moved into the Medicare levels of things yet, but are getting some basic care through their state governments and Medicaid, either because they could be of all ages, especially like mothers and children who are uninsured are often covered in Medicaid as part of that welfare process, but also people that are disabled are covered under Medicaid. And if Medicaid cuts come in to play, again, those people that may have a primary care resource through their Medicaid funding are unable or unavailable to them because of the funding cuts, might then turn to EMS for primary care. So it's important for you to understand that. There's an article I picked up on Reuters.com looking at health consumers making the deficit fight personal as the government continues to go through these deficit spending packages, trying to balance the budget and do all these political things. You know, no matter how you feel about those types of situations, healthcare is one of those things that people are going to have some real effects on their lives and their abilities to take care of themselves and their loved ones if their healthcare, as little as it may be, gets cut. And so there's a great article looking at how the numbers might affect given areas if there are major cuts to Medicaid and Medicare, and how individuals are reaching out to their lawmakers and also physicians and corporations that are dealing in healthcare, because of course cutting funding also means cutting reimbursement, and this could affect your ambulance services. If they cut Medicaid or Medicare reimbursement for ambulance services, if they begin more carefully scrutinizing and deciding they're going to disallow certain transports, you may not get reimbursed. And if the patients don't have the money and you were expecting Medicare to pay the bill for that ambulance transport and the patient doesn't have any money to give you, you're going to have a hard time keeping the doors open in some of these situations. So there's a lot of levels of effect here, and it should be looked at not from just from the patient side of things, but also from the healthcare side of things. If we are unable to provide healthcare and some of the services we provide because our funding is getting cut, our funding resources through Medicare and Medicaid are being cut, then we will have to make cutbacks as well. And that could be in personnel, could be in units on the street, could be maintenance or equipment that we need. So all of those things can affect you, and you should keep these things in mind. There's a lot more going on in these debates than just discussions of where the dollars are going to be spent. Cutting back Medicare and Medicaid could have widespread effects across the healthcare systems, including EMS. Next up is a great article I found looking at stroke treatment and looking at how we handle strokes. And one of the things that it looks at in this particular article on medicalnewstoday.com is looking at how doctors apparently are not using some of the medications and resources that are available to treat patients with strokes when they come in with a risk for stroke. And a lot of patients, if you think about some of the things that are causing risks for stroke, one of the primary coronary or cardiac problems that we see in the EMS sector is things like AFib or aflutter. Patients with a supraventricular arrhythmia that causes them to be at risk for throwing a blood clot. So if stroke is a problem, and in this article they're looking at a study out of Australia, it's the second biggest killer after coronary heart disease, biggest cause of disability. It's the same here in the United States. The study found that of those with atrial fibrillation, the mortality rate's twice that of other stroke patients. So AFib patients have a higher mortality rate than other stroke patients. And is this because we're under-treating AFib or mishandling AFib patients? This is something that you should be aware of, because we often see a lot of these patients when they are having a problem with managing their atrial fibrillation. Perhaps they're taking a calcium channel blocker, they're taking a medication to deal with their AFib, and that medication, for whatever reason, is not working for them. Either they didn't take enough or they've changed. Dosages need to be adjusted over time. we need to be proactive in recognizing, A, the arrhythmia. What are we looking at? So you need to be proficient in reading your ECGs. You also need to be understanding the risks and physiological things going on with atrial fibrillation. We don't want to be going in there and inappropriately cardioverting an AFib patient when they're stable, because we could risk throwing a clot. Again, that pooling of the blood in the atrial spaces. If we restart the atria to a more normal rhythm and they start pumping those clots through the system, we end up with patients with either pulmonary emboli or throwing clots and giving patients strokes. So we need to manage these patients appropriately. So this is all part of the process. And again, it's part of looking at how EMS and your system in particular fits into the larger healthcare system in your area. And this is sometimes very personal to every community. What you do in your system might be slightly different than a neighboring system. Your protocols are different. Some of you may have access to thrombolytics to start dealing with these patients, depending on your system. So something to keep in mind, and I wanted you to be aware of this particular article. Next up, another article about strokes. This is about TIAs, or mini strokes, those transischemic attacks. The transient ischemic attacks occur to patients, and as we've talked about here in the past on the show, when we've talked about stroke more in depth on a tip segment, TIAs are often a precursor to a full-blown stroke. In other words, somebody who's thrown a small clot that is self-resolving and they have stroke symptoms that resolve after an hour or so on its own are often means that they've got another clot lurking out there. They've basically thrown off a piece of a bigger clot, and when something bigger comes along, it's going to cause a full-blown disabling stroke with longer-term consequences. So managing those TIA patients, again, is a great way to help stave off stroke. And there's a great look here at a study coming out of Denmark. 306 patients admitted to the hospital with TIA found that when they were managed acutely as part of the stroke protocol and really dealt with those patients as if they'd had a regular stroke, not just a TIA, that they were able to reduce the mortality rate and reduce their risk of having a clot within the weeks and days following their TIA. And so we have that. We know that TIAs are often followed by a stroke, so we need to educate ourselves on how to manage TIA patients. We need to educate those patients. We may show up and they're already feeling better, right? Quote unquote feeling better. So we need to educate those patients, hey, I know you're feeling better because you had what you thought was a stroke, but now you don't feel like you have a stroke anymore. You had a stroke. It's just what we call a mini stroke. And here's what we need to do. We need to get you to the stroke center in our area, whoever that is, and we need to get you in there and have you checked out fully, because you could have another stroke that's more permanent right away. And we don't have any way of predicting that, but this puts you at much higher risk. Understanding that as an EMS professional, it's really part of your job, especially at the paramedic level, so that you can educate your patients about making an intelligent decision, an informed decision about their care, and when it makes sense to have a refusal and when it doesn't make sense to have a refusal. The other side of that is, you shouldn't take a refusal from a TIA patient. You should be calling the hospital, getting the doctor involved, having them talk to the patient, whatever the case, whatever you need to do. This is just like that chest pain patient that you think is having a cardiac event and refuses to go to the hospital because they feel better. You need to encourage them to go to the hospital and get checked out. The same thing is true for a TIA patient. Just because their symptoms have resolved or started to resolve by the time you get there doesn't mean that you don't think this is an emergency situation. And you'd hate to, have that TIA patient sign that refusal because you kind of went easy on them, and you come back an hour later, 2 days later, 3 days later for a patient with a full-blown stroke that is now going to have a major disability because we didn't manage them more aggressively as EMS professionals. And that means we're medical professionals, and we're part, again, of that whole system of care. We need to be thinking about the long-term outcomes of what we do with our patients, not just whether or not they need to go to the hospital, which hospital we take them to, but what is their long-term outlook by making the decisions we make for the minutes or few hours we might have them. So something to keep in mind. I urge you to check out these links in the show notes. You'll find them over at mediccast.com/blog. There's a link for the show notes right at the top of the page. Click that link, follow through with what you have here, and check out these articles for yourself. And then, think about how you'd approach these types of patients as you go through your practice as an EMT or paramedic. Let's go ahead and move into our tip of the week. And we're going to be talking about the physiology of pain in this episode. And this goes into my belief that we need to really be educating ourselves more about what's going on with our patients, be more proactive in our care, and be more part of how we interact with our local healthcare systems and working with using what we have available in our protocols, as well as understanding how we can better affect patient outcomes at the other end of their hospital stay, whether it's a brief visit to the ER or they end up getting admitted and having some protracted treatments and coming out the other end. It all begins with how we handle them in the field. And some things and decisions we make can have long-term effects. And that includes how we manage their pain. So I thought I would talk to you a little bit about aggressive pain management, and we're going to talk about that in terms of what's going on with how pain works. And to do that, we need to cover physiology of pain. So this is part one of physiology of pain. We'll review some of the basic structures and ideas surrounding how pain works. And then in our next episode, the second half, we'll talk a little bit more about specific interventions and a little bit of understanding of how we manage pain and what we can do to be better able to manage pain. And then in an upcoming episode, we're actually going to have a pain management nurse coming on. I'm trying to get that interview lined up now to come and talk to us about managing pain for patients effectively, and some of the things you can keep in mind as you deal with those patients, and maybe even have a panel discussion surrounding that with maybe some other paramedic leaders to talk about managing pain specifically in the EMS sector. So I hope you'll look forward to that. Without further ado, let's jump into the physiology, part one of the physiology of pain. We're going to be looking at a couple of things. First, what is pain? It seems kind of silly to talk about a topic if we really don't define it first. And it might be easy for you to say, I know what pain is, but do you really? Let's define it. We'll also talk about why it's important for us as EMS professionals to study and to manage and treat pain aggressively. So we'll talk about that. We want to review some things with the physiology and the anatomy of the central nervous system and peripheral nervous system. It's important to do that so we can understand what's going on. We'll look at pain transmission pathways, perception and interpretation of pain, because that's so important in assessment and also in how we manage and treat pain. And we're going to talk about some specific care considerations to keep in mind when you're dealing with patients with varieties of different types of pain. First off, what is pain? Defining pain is important. One definition I found that I think really describes it very succinctly is physical suffering or discomfort caused by an illness or injury. I think that's very straightforward. There's several different types of pain we can talk about and break it down even farther, talking about acute versus chronic pain. We have those patients that are dealing with acute pain, and that is basically related to a sudden onset on a specific illness. We can tie the symptom of pain back to a cause very easily in acute pain settings. The patient broke their arm. Guess what? They have arm pain. Why do they have arm pain? They have a broken arm. We can look at that and say, I understand acute pain. Chronic pain is a little more elusive in finding either the cause or if we have a location, what the specific cause in that location is. And people live with chronic pain. There's a lot of things going on there. There are subcategories in these areas too, inflammatory, neuropathic pain, other types of pain. So we're going to talk about some of those different types of pain we might see as well. And then, do we have a specific symptom and location, or is there an unidentifiable cause? And again, that comes back to that acute versus chronic pain setting. It doesn't necessarily, in the EMS setting, change how we manage that pain, except that sometimes our protocols limit our ability to manage chronic pain patients. And I think that's a problem and something we'll talk about maybe a little bit later on. Why do we need to focus on pain? There was a recent Institute of Medicine report that looked specifically at healthcare and management of patients with pain. And looking specifically at just chronic pain sufferers, it found in the United States 116 million people suffer from chronic pain every day. Look at that. I mean, we're talking about a third of our population on a daily basis is dealing with some kind of chronic pain. I would argue that probably people co-workers in EMS are dealing with chronic pain. We're talking about patients, people with back pain issues related to back injuries, people with all kinds of things. We have people with arthritis, with fibromyalgia, with long-term injury-related pain. Sports injuries often can cause chronic pain down the road. So chronic pain suffering is important to be aware that this spans a huge amount of our population. What's the number one thing we get called for? We get called for some type of pain related to what's the patient's got going on. There's a cost associated with unmanaged pain. We don't often think about it, but if you think about people that are dealing with pain, the Institute of Medicine report found that $635 billion spent each year in treatment of people with chronic pain and in the economic impact of patients with chronic pain. Lost work days. Think about it. If you or one of your coworkers suffers from a back injury related to patient lifting or something like that, what is the cost associated when you have a flare-up of your back injury? You can't work. You may not get paid because it's not clearly a workman's comp issue, or even if you do get paid for workman's comp for your back injury, think about the cost to the economy, to your workplace, to everything else that goes along with that. If we could manage pain better, if we could deal with chronic pain more effectively in some way, we would have more money in every business out there to maybe give everybody a raise. Think about those kind of things. This affects everyone. So keep that in mind. There's a very real economic impact associated with chronic pain care. Also, there's a shift in focus in healthcare in the last 50 to 100 years away from care of our patients and into looking at curing our patients. And that's partly to do with the huge advances that science and medicine have made in the last century and into this century. And it has to do with the fact that, hey, we can now cure things that we couldn't cure 50 or 100 years ago. Up till that point, all we could do was try to make the patient comfortable. So pain management was a huge part of the healthcare process. We managed pain as best we could because we couldn't cure the problem. Now we have the ability to cure, and I think one of the problems is that we've gotten away from managing pain because, hey, we can cure. Put up with a little bit of pain now because I'll be able to cure the problem and you can deal with that. What we're finding is that people in pain don't heal fast. People in pain have a whole bunch of other medical problems going on that hinder their ability to be healthy and actually affect them long term in how they deal with pain and how their overall health reacts because of ongoing untreated pain. So we really need to really think back to why did that shift happen and what did we lose when we stopped really caring for our patients and saying, I want to make you comfortable, I want to help your pain go away. And yeah, we're going to cure you, but let's take care of your pain because that's your problem right now. So the Institute of Medicine asked for a couple of things. They came out with this report, and one of the things they said was we need a culture shift, and they issued a public health challenge. They said we need a shift in healthcare culture right now on how we deal with pain. And it goes back to that care versus cure argument. We need to re-educate nurses, doctors, and the rest of our staff, including all allied health professions. And that includes us folks. So often we get left out of the healthcare picture. And yes, the Institute of Medicine didn't mention EMS because we get left out of the picture, but that doesn't mean that we don't have a responsibility to try to work as healthcare professionals anyway. And they are talking about us here. We need to re-educate ourselves in how we handle pain. We need more research. In a lot of cases, this is in nursing research or other types of research that are really upfront and personal with pain. I would argue to you that in the EMS setting, there are opportunities for pain management research as well. And that may come in tandem with a hospital research project. So talk to your hospitals. They often have a pain management specialist, either a doctor or often it's a nurse or a group of nurses that are the pain management nurses for the facility. Make an appointment, sit down and talk with them. Tell them what you're going through, what you're looking at, and what you'd like to see done in the field. And maybe they can help you put together and work with you to have a joint hospital EMS research project surrounding how pain is managed effectively and look at patient outcomes when pain is managed more acutely in the field. There's a need for research on how that affects long-term care and outlook. And so we need to have support for really collaboration between everyone. This means that if your protocols do not have an aggressive pain management policy, that you talk to your medical director or go through the appropriate channels and say, why don't we have an aggressive pain management policy? I can tell you, in my nursing side of things, if you look in the ER, if you work around the ER a lot, you'll find that, nobody wants to listen to someone moan and cry. So the doctors are very quick to manage pain in the ER, if only because they don't like listening to it. Okay, and I'm not saying that's their only motivation. I really think that the focus on pain management has started to change significantly. But in the ER, a patient who we would never be allowed to give pain management to in the field, the first thing they do when they come in the door is give them a dose of an opioid pain management so that they can get them settled down so their pain is managed. I would say that's a disservice that we don't provide that in the field. But we need to talk and say, look, doc, we know you do this when you get them to the ER. Why aren't we managing their pain more aggressively in the field? What can we do? And this is where you need to say, you're not letting me do what I can do. You need to say, what can we do to make you more comfortable with writing that into our protocol? What kind of education? Do we need to sit down and do a separate class on pain management so that you can say to your other base station physicians that, yeah, we need to be more aggressive and let them have bigger orders for better pain management in the field and write that into your protocol. This is about conversing as a medical professional with another medical professional, and it's part of that. So let's look at the central nervous system. Let's do a review here and talk about what's going on with the central nervous system. Let's do a review. The central nervous system consists of what? The brain and the spinal cord. So that's pretty straightforward. There is white matter and gray matter. The white matter consists of the axons of the long nerves. So remember, we picture a nerve cell in our brain. You've got that ball with the hairy thing sticking off of it. That's the cell body, and the dendrites. That's where signals get sent and received. The received signals come into the cell body, and then it transmits down the long axon, and that axon is covered often with a myelin sheath. It's kind of, think about it, wire insulation. It's the insulation around the wire. It's a fatty insulation that allows for rapid transmission down the axon to the other end, where that signal is then passed on to its target cell, target structure, or another nerve cell. And that's the white matter, is that axon. Think about the color of fat. Fat is white. When you look at a piece of meat, you got that white marbling, that's the fat. So think about that, and that'll help you remember what the white matter is. It's the axon and the myelin sheath, basically the wires that send the signals. The gray matter is the cell bodies and the dendrites. So, the part that receives the signals and then decides whether we're going to send a signal down our axons, our white matter, to the next place. The meninges is also part of the central nervous system. Again, these are the three-layer membrane that covers the brain and the spinal cord. And from the outside to the inside, we have the dura mater, the arachnoid membrane, and the pia mater. And these are the three membranes that cover and also contain the cerebrospinal fluid and are really there to protect the brain and the spinal cord. The spinal cord has white matter on the outside and gray matter on the inside. And think about it, that makes sense. The spinal cord, is down there in the body, and then the signals are going out from the spinal cord. So the cell bodies are in the center, the gray matter on the inside, and then on the outside are where all the wires are sticking out to connect to everything. So that makes sense. Gray matter on the inside, white matter on the outside. The brain is a little bit different, because now we've got all those signals coming up into the brain. In the brain, the white matter is on the inside, because that's all the wiring coming in, and then the gray matter is on the outside. That's because that's where all the work's getting done and where all the cell bodies are, and that's where the mind and decision-making goes on in the cell bodies. So it'll help you kind of think that, again, the wiring is the white matter, so the wiring's coming into the brain, so it's on the inside, and in the spinal cord, the white matter is on the outside because the wiring is going out to the body, so it's on the outside. There are 31 pairs of mixed spinal nerves, and they consist of both sensory and motor nerves that come in. Sensory input comes into the dorsal root ganglion, which is a collection, a bundle of nerves, and then into the dorsal horn or dorsal root of the spinal cord. The motor axons come in via the ventral roots. So there's two sides, the dorsal and ventral sides of the spinal cord. The ventral side is where the motor input comes in and goes back out, and the ventral side, the dorsal side, is where the sensory input is processed. What about the peripheral nervous system? Okay, well, we talk about the peripheral nervous system. We can't do that without talking about the somatic and the visceral nervous system. So somatic nervous system is the conscious nervous system. It's where we, say I'm going to walk to there, and I send a signal to my legs to walk. The visceral nervous system is the autonomic nervous system, and this consists of several different things going on, including the different aspects that run the different parts of our bodies, our fight or flight syndrome, when we're talking about dealing with some of the things that are releasing epinephrine. All that stuff gets done behind the scenes, doesn't require conscious thought. Sensory nerves, motor nerves, and the nerve ganglia and interneurons are all part of the peripheral nervous system. So you have those nerves that are going out to the body and connecting and saying, here's where the nerves connect. We're receiving sensory input and going into the spinal cord. We have motor nerves that are sending signals back out to say, this is how the muscles move and do things. Nerve ganglia are where collections of nerves come together and then gather their input to send on to the spinal cord. And interneurons are actually neurons that are sending signals between two neurons. And they're often shorter. They're often used to send reflex signals. So you stick your hand in the fire, it sends a pain message to your spinal cord. That message gets sent to your brain. But before your brain ever gets the message, hey, your hand's on fire, an interneuron has taken that message, and if it's hot enough, sends a message back down the motor side of things to do a gross motor movement to get the hand out the fire, right? So we're going to go ahead, and interneurons often are used to transmit messages between different parts of the system. The enteric nervous system is a part of the autonomic nervous system. It's a subsystem. I just mentioned it here peripherally because it exists, and you might run into it if you're looking at a review. The enteric nervous system can operate on its own. So even patients who are paralyzed at the point where you would think they could no longer process food, guess what? The enteric nervous system, the part that runs your GI tract, actually can operate independently on its own to go ahead and process food, and does so. And so that's important to just keep in mind. It exists, and I wanted you to be aware of it. So let's look at pain transmission pathways, and this will be kind of wrapping up part one here. We've looked at the structures and how they work, the brain and the central nervous system with the brain and the spine and the peripheral nervous system. What are we talking about? How does pain get transmitted into the system to begin with? Well, there are certain types of receptors. The pain receptors are called nociceptive receptors, and that's nociceptors sometimes. They consist of three types of receptors. They are receptors for pressure, heat, and chemicals. So the pressure receptors basically are there to sense trauma. A certain amount of pressure will cause a reaction. The heat receptors are there to sense heat, obviously, heat and cold. And the chemoreceptors are there to sense the presence of dangerous chemicals, either often from the damage caused to the surrounding cells, leaking of the internal cellular components. Certain chemicals are present there. When these chemoreceptors sense those chemicals, they know cells have been damaged, and if a certain amount of those chemicals are present, they will transmit a message saying, hey, these are present. Incidentally, chemoreceptors are affected by not just outside forces and chemicals, but can be affected by the release of internal chemicals, even unrelated to a specific injury. And this is thought to be one of the reasons why people will sense pain associated with chronic pain related to the release of chemicals and the sensitization to certain chemicals by the chemoreceptors and the nociceptive receptors. This is a threshold-based transmission. So, when you lean up against a wall, certainly you're causing pressure on this pressure sensor in the nociceptive receptor, but you don't have a pain response. So how does this become pain? Well, everyone has a threshold that works there, and that threshold has to be met. A certain amount of information has to come into that receptor before it says, okay, I'll send this message on to the brain. All right, so picture a little guy sitting in there, and he says, until I get 20 messages, I'm not sending a message on. So he gets a message, 2, 3, 4, 5. Nope, not enough for me to tell somebody you have pain. All these receptors work that way, and it's important to understand that because guess what? That threshold can be enabled or disabled depending on patient's past experience, depending on the individual patient, depending on a lot of different factors, so that patients may sense pain much more easily in some situations than in others, given the same amount of sensory input. And that's important to understand because it can relate directly back to how aggressively pain is managed, both in a current event and in previous events. We also can look at a picture, and if you're looking at the video version, you'll see this. If you aren't, I urge you to head over to the site, just fast forward to the middle and check out. I kind of drew a picture of how this process works so you could get a sense of it. You have the nociceptive receptors, a big thick red line. That means that you have that threshold-based system. And then there's a reflex impulse that may come back, and that's related to that interneuron play. So this is an important part of our safety process. When we get an impulse, even though transmission to the brain is very rapid and transmission back is very rapid, the great defense mechanism we've developed is that the spinal cord actually has the ability to do some limited decision making on its own. So there's another threshold-based mechanism there that says, hey, you have pain. It's a lot of pain, it's a significantly damaging amount of pain, and we're going to send a message back to the large motor cells. This is not fine motor control, but basically a gross motor command to, hey, move that body part out of that situation. So you jerk your hand out of the fire when you incidentally stick your hand in the fire without realizing it, or you pick up something that you didn't realize was hot. The reason you're suddenly let go of that hot pan, really even before your brain registers heat, is because your spinal cord sent a message to your hand saying, let go, idiot. That's important to understand because that occurs automatically. And then the signal continues anyway onto the brain for processing, for saying, ow, that hurts, and how much does that hurt? And that's not just a conscious part. So we'll look a little bit more in depth at that. That signal comes into the dorsal horn of the spinal cord. Remember, the two parts of basically the back. Okay, the back. If you're looking at the individual, this would be their dorsal side, or the back of their spinal cord as you're looking at them facing you, rather than the front side of their spinal cord. Dorsal horn of the spinal cord, and then it's sent to the brain where it's processed. The brain assigns a severity to it, and then it moderates that signal. And it's this moderation that I really want you to take away from this message here, because this is why aggressive pain management is vital and why EMS can make a huge difference in these patients long term through aggressive pain management. Because the brain doesn't just say, hey, that hurts, do this, and sends a motor signal. It also has a moderating signal that goes back down through the sensory pathways, and it makes a decision on how it's going to manage the pain long term. It's going to say, okay, nociceptive receptors, I want you to be more sensitive to pain because we need to be aware of this and get away from it faster next time. Or it may say, hey, nociceptive receptors, I want you to be less aware of pain and be able to handle more pain before you send me this signal. It's not a conscious decision. This happens at a very autonomic level in the brain, actually happens in the brain stem itself. And this is important to understand because it seems some studies are starting to point to the fact that we can change the way this moderating effect works long term by how we manage pain up front. In other words, we treat pain with the big guns first rather than saying, well, take a Tylenol and let's see if that takes care of it. Okay, that didn't take care of it. Okay, let's take a Percocet. That didn't take care of it. Okay, let's give you some morphine. There's the studies are starting to say that for acute pain at least, we should be handling pain with the big guns first and managing pain very aggressively early on, and then slacking off as we can as the pain becomes less severe as the patient starts to heal. So that's going to wrap up part 1 of our Physiology of Pain segment, and we will be moving into part 2 next week. I want to urge you to check out some of the links in the show notes. I've provided some links to some additional materials and references that you want to check out in this segment, and there's some great resources available for you in numerous places over there to look at how you manage pain, as well as just review your protocols on pain management. What are you or are you not allowed to do? And this may be an opportunity for you to spur a discussion with your training officer, with your medical director, to really talk about maybe having a bigger focus on pain management for your system. And that's going to wrap up this week's episode of the MedicCast. I want to thank everybody for checking out the program this week. Again, remind you to find links to everything we talked about in the news segments, as well as our tip segment this week, over at mediccast.com/blog. Of course, if you're watching the video version of this, you can go directly to any of the video versions, and there are links to show notes pages over at mediccast.tv, and that'll help you out there as well. But either way, go back and check on these resources and really follow up on what you heard here on the show. I'd love to hear back from you. You can leave a comment over on the MedicCast blog if you want. That's always available for you, and it's a great way to leave those comments and then have other folks share their comments back with you and have a bit of a discussion. Or you can go ahead and reach me directly. You can, of course, go ahead and send me an email to podmedic@mac.com. You can also call in on the voicemail line 941-306-3342, 941-30-MEDIC, and you can go ahead and become involved in that way. You know, we had that great voicemail at the beginning of this episode. I would urge you to call in and use the voicemail line as well and share your thoughts about pain management, for instance, or any of the news items discussed in this episode. Love to hear from you. Again, I try to get back in touch with everybody I hear from, so if you are sending me a message, and either by voicemail or by email, go ahead and keep those coming in. I love to hear from you, and I will get back in touch with you, even if it's just to shoot you an email back with a few comments or just a thank you for getting in touch. You can always reach me over on Facebook and Twitter under the handle Podmedic. So facebook.com/Podmedic or twitter.com/Podmedic for my personal pages there. And don't forget to become a fan of the MedicCast over on Facebook, facebook.com/MedicCast, and become a fan of the MedicCast there. See what's going on, share your comments, and you can always leave links to things over there. Another great way to become part of the MedicCast community. That's it for me. We'll be back again soon with another episode here on the MedicCast. Try to bring them out for you every Monday, and you'll find those here on the MedicCast, as well as available for you in iTunes, so you can subscribe there. If you're a user of an iPod or an iPhone device, you can get them subscribed to and linked directly into your phone just by syncing your phone right there every morning on Monday and get those episodes brought to you directly. So check that out. Of course, you can find us in numerous other places and over at the ProMed Network at promednetwork.com, along with some great programs from other EMS professionals. I'm Jamie Davis, the Podmedic. Be back soon. In the meantime, please remember, scene safety, BSI.